Thank you all for joining us this morning for Key Goals for Diabetic Management, the Pediatric and Adult Perspectives with Dr. Bruce Buckingham and Dr. Rayhan Lal. Just a few housekeeping details. There will be a Q&A at the end of the session. Please hold your questions till then. We'll allow time for Q&A at the end of the session. If you have an elementary or kiddie cove child, they'll be released at 10 o'clock. If you have a tween or a teen, they'll be released into the wild to their predetermined meeting location, wherever y'all have worked out. We really would love your feedback for this session. There will be survey forms provided on the tables. Please fill those out as you leave. And masks are not required, but if you feel more comfortable wearing one, please feel free to do so. So thank you all.
Okay. So thank you very much for being here this morning. And it's a combined session. So I'm a pediatric endocrinologist, and Rayhan is a masochist, I guess. He is both a pediatric and adult, board certified in both endocrinologists. So he's really followed children into his clinic and into adulthood, and is going to give a great perspective on that. I just wanted to make a comment just sort of about healthcare and delivery. The Richard Rubin Award that was done yesterday for Jeff. I worked with Richard Rubin at this conference for years, and at Children with Diabetes conferences. And the last conference he gave here, I had seen him at the ADA a few weeks earlier, and he had pancreatic cancer. He was going on chemotherapy between the ADA and coming here. And he did all his sessions. He talked to all the families. I did a grandparent session with him. If you knew him, you could tell he was thinner. And if you looked at his face, you could see he was in pain. And he never once mentioned that he had any problem, didn't self-refer, completely was focused on the families and the people he was seeing when he was there with them. And that's the sign of a really good healthcare provider. He was amazing. I can remember times over the years, I just get a little tweak in my email. Bruce, thinking of you. How are you doing? And just nice little gestures like that. And having a healthcare provider that's thinking of you, has done something. Sometimes you make a decision and you wonder, was that right or not? So I'd call people up and say, hey, how's it going? And it's that type of care that I think really is exemplary, and you can't find it in everyone, but you can find it in a lot of providers and CDEs and educators and all the people you come in contact with. So I'm going to do a little bit of what Jeff did yesterday, and I'm going to give sort of a historical perspective a little bit. So I went back and I found sort of my first talks that I gave here in 2004. And I just want to say this whole conference has talked about diabetes management. And, we've talked about psychological issues, with school issues, with the different age groups that people go through. And in pediatrics, we have toddlers, children, adolescents, and then the young adults. And there's been talk on technology. So the whole conference is sort of dealt what this topic is about. But when I started out, there was urine testing, and we had no idea what the blood sugars were doing. This was, we were just flying blind, and this is how we managed diabetes. Then in 1980, we got finger pick blood glucose monitoring, and that lasted for a long time before we got sensors. It would be almost 12, 18 years. And this is called the guillotine, affectionately by the kids. And then the sensors, when they started out in 2006, really got good enough by 2014 to really use in automated insulin delivery and closed loop systems. This is the first pump I used. It was in 1979. It was called the Big Blue Brick. It was made, do you know who made this brick? Rayhan does. Dean Kamen, the guy that made the Segway. So he was the guy that made, and this is a pump he made for us when we were going to do automated insulin delivery. Big change in size. This was a kid I was seeing in my clinic. This was another kid, and you can see they're pushing their hands together and they can't get their fingers together. And they had joint contractures and very thick and tight skin. This is another girl. I went to a diabetes camp. I went through all sessions of a diabetes camp, 375 campers. 50% had thickened and tight skin. 19% had decreased lung capacity. 17% had one joint contracture, generally the fifth, and 16 had two or more. 16% had two or more joint contractures. This was really common. I biopsied the skin. This is normal skin over here, and this is the skin from one of these children. And you can see the skin is really thickened and tight. This is the collagen basement membrane of the skin. And that basement membrane is also found in the kidney. It's found around the blood vessels of the eye and is formed of collagen. Collagen has a half-life of 15 years. So that protein stays in your body in adults for 15 years. In kids, it turns over much more rapidly. So it doesn't last as long. So in pediatrics, if you're running high for a while, you're going to be making new collagen and replace collagen that may have had glucose attached to it. In here is also the is cartilage, which has a longer half-life of 117 years. So when you look at a skeleton, you can see cartilage there still, you don't see the skin. And the brain actually has myelin where glucose can attach. And we have seen changes which are really based predominantly on high glucose levels in children. This is the diabetes complications trial, the trial that shows that as you tried to get a lower A1C, you got a much higher incidence of severe hypoglycemia. And then we added CGM, the JDRF CGM trial, and we did much better, getting an A1C of 7 with about a 20, rate of 20 per 100,000. And then we added a sensor augmented pump. And then when we finally got to automated insulin delivery, we could get an A1C of 7 without any severe hypoglycemia. That was a major improvement. So when we looked at this current state of diabetes, we always show this, and this is where the A1C target used to be for kids at 7.5. Now the target's across the board at 7. But this is with insulin-only closed-loop systems. We can get there. And with the bihormonal, we even got a little bit lower. So we can achieve those goals now. What does that mean? This is the DCCT data, and here is an A1C of 7, very low incidence of any problems. And this was 8. This is about 20%. 9 is 50. 10 is about 80% risk of complications. That was done many years ago. So a more recent study out of Sweden looked at about 11,000 children and adults that they followed. So Sweden has actually organized healthcare, unlike the United States. Here we are, the richest country in the world, and we can't track or follow our people or our citizens or provide them healthcare at a reasonable cost. But they provide that all. And they were able to track everyone. And this is the very earliest stage where you might get a microaneurysm in your eye. Here's an A1C of 6.5. Here's an A1C of 7. Here's an A1C of 7.5. And here's an A1C of 8.5. And you have to look, because of that long half-life of collagen, you have to look at the group that's had diabetes for 16 or 20 years, which is this group here. And you can see at 7, there's almost nothing. And that's just the very earliest stage. Oops. If you look at, I'm having problems here. If you look at proliferative, that's where you need to get laser treatment of the eye. At an A1C of 7 after 16 years, nothing. This is 7, this is 7.5, and this is an 8.6. So we are doing so much better amount. Those contractures I showed you at camp, I've been going to camp for the last 8-10 years, have not seen one. No one has that anymore. We don't even study it. It's not published, it's just gone. If you talk to people in other parts of the world who don't have the healthcare we have, they still see it. It's still a problem if you're on MPH insulin and finger stick poking. So I just want to go through, this is the slide talk I gave in 2014, and just was talking about issues with toddlers. And none of these things have changed to a large extent, but they may refuse to eat. They can have temper tantrums. You got to distinguish a temper tantrum from hypoglycemia. And we didn't have continuous monitoring then, so that just meant a lot of finger pokes to decide how to handle the behavior, to see if you put them in their room or gave them some carbs. And preschoolers, childcare providers become more involved, so the child is away from you. Now we have, remote continuous monitoring. You can follow them. The healthcare providers can see what their glucoses are, and the school personnel can. Some of these psychosocial issues, fear of injections. Now you had the little video last night of someone being afraid of a Dexcom going in. But the fear of hurting your child when you're doing all these procedures on them, for the child feeling different. And I think the biggest problem that I've seen over the years is when someone decides they're going to keep their diabetes in the closet, and they're not going to let their other friends know, the other people at school know. And it means they have this sort of dark feeling about themselves. They have to go hide and do something someplace else. They're going to the bathroom, they're going to the nurses, they're just not doing anything in public or letting anyone know, and you just don't feel good about yourself. And so every time a kid gets diagnosed, one of the first things I ask them to do is give a presentation to their class and explain to the class what diabetes is, and really come out and never try to hide it. And proudly wear their devices so that someone can ask you a question and you can be an ambassador. So the other issues are learning to share responsibilities. Parents need to let go at some point in time if you've had a younger child and give more responsibility to the child. Sometimes you don't want to do it too soon. So there's some people just want to say, okay, you're old enough, it's yours. And you can't always do that and get a successful transition. So adolescence, it is that transfer of responsibility. You're dealing with potentially alcohol, recreational drugs, driving, getting the responsibility of driving and not driving with a low glucose, dating, and this is a little while ago, but the other thing, of course, is sex when you date, employment, benefit of diabetes camps, peer support, and counseling. And I just strongly recommend places like this where people can get together, share experiences, and kids can get together. So many kids, the incidence is 1 in 300, and a kid in his grade may not have another kid with diabetes. And if you have someone in the school that's 2-3 grades older, they're in a different universe. It's a different orbit they're in. So it's really important to have friends. And the bonding, I've never seen kids get ostracized at a diabetes camp because everyone has something in common. It's really such a delightful group to be with because they care for each other. This was poor growth. You can get hypothyroidism, celiac disease, Addison's, where you lose adrenal. That's quite rare. And we used to see Moriac, where we'd see poor growth, large livers, this cushingoid appearance. That's gone away. Haven't seen that. Have you ever seen one? Yeah, but yeah, well, I did too, but it's been many, many years in our practices. So we talk about exercise. Exercise should be encouraged. It should be 60 minutes a day, how to treat with snacks. And it's much more complicated when you're in automated insulin delivery. You have exercise hyperglycemia. Desi was talking about that yesterday when she was doing one of her competitive matches, and her blood sugar shot up to 400 and she became foggy. You can also have the late lows after exercise, where the muscles have been depleted of glycogen and need to be restored. The insulin requirements prior to puberty and post-puberty are generally around 0.5 to 1 unit per kilo. But in puberty, it goes up much more than that. It's 1.5 units per kilo. At this time, we were starting 2004 with MPH at breakfast and Lantus with dinner. Now we probably are starting a lot of kids on automated insulin delivery within a month. This was the other slide from this talk. I was very excited to show this because this was the artificial pancreas dog studies that had been done at Medtronic, the first ones. And they had done 10 adults. And it was an abstract at the ADA meeting that year in 2004. The very beginnings of getting things going. Also, we looked at what it meant to have an A1C of 7, that goal. And this was with blood glucose tests. Now, remember, when you did a blood glucose test, you did it maybe before meals, and if someone had symptoms of a low or high. So you might get 5, if you're 4 to 6 tests a day, not 288 readings a day. So for your A1C of 7, you'd have 18% low, about 50% range, and 33% high. That was what you would see when they studied capillary blood glucose levels from almost 280 kids. Now, when we look at a time in range, we base that on 288 readings a day, getting a much fuller picture of what's happening after a meal, what's happening overnight, and it isn't skewed at just testing when you think someone's really low or really high. You're seeing the full day. So you see a lot more better time too. And it looks a lot better. So we expect to see 70% within target on CGM, and the low should be less than 4%. So coming to 2022, the ADA guidelines, glycemic monitoring should be offered to all children. Device is their choice. Automated insulin delivery should be offered to all children. Device is their choice. Pump therapy should be offered to all children. Pump is their device. Students should be supported in school in the use of diabetes technology. An A1C of less than 7 is appropriate for many children, but must be individualized and reassessed over time. Less stringent A1C goals, such as less than 7.5, may be appropriate for people who can't articulate symptoms of hypoglycemia, of hypoglycemic unawareness, lack access to insulin analogs, advanced insulin therapy, or CGM, and cannot check their blood glucose regularly. And if they have other non-hypoglycemic factors. And this is alluded to the fact that CGM, I think, really measures your risk of those long-term complications because it's a sensor in the subcutaneous space measuring the glucose attaching to the collagen. Unlike an A1C, which is an indirect measure and is based upon the red blood cell lifespan, which a lot of things can affect. So they're acknowledging that if you have someone with good CGM data that's getting their 70% time in range, you should, and it's the glucose management index, which is based on CGM data instead of an A1C, that may be the measurement you should use and not an A1C. All these things, we say A1C, but I would prefer we begin thinking of the GMI if you're using a CGM. And you may suggest more stringent A1C goals if it can be done without significant hypoglycemia, without an increased burden, and it won't have negative impacts on their well-being, like being driven crazy to try and achieve that. And again, those who have abnormalities in the red blood cell, where it would affect the A1C, you could try for a lower value, but if the mean glucose is actually saying you're at an A1C of 7, and the A1C says you're at 6.3, you should aim for what that CGM tells you. And during the honeymoon, after first diagnosed, when you're making your own insulin, you can do very well. And so we just completed a study putting kids on closed loop at the onset of diabetes. And our target for time and range was 85% for them. We wanted to see them at least 85%. And most of them got there for over a year. They state CGM metrics should be used in conjunction with A1C whenever possible. The testing that you get done when you go in, this is one of the reasons to have a physical visit at least once a year instead of a Zoom, is you can get thyroid testing at diagnosis with the TSH and antibodies. And then every 1 to 2 years, celiac disease should be screened for within the month of diagnosis, and then within 2 years, and then again in about 5 years. The BP goal should be less than the 90th percentile based on age, sex, and height. And if they don't do that, you can have an erroneous value depending on someone's age, sex, and height. So they got to look at that. LDL cholesterol should be done within a few weeks after diagnosis if you're over 2 years of age, and then around 9 to 11 years of age. And you can use a non-fasting with the goal of less than 100 milligrams per DL in the LDL cholesterol. The annual morning urine for microalbumin should begin testing for once someone's in puberty and they've had diabetes for at least 5 years. You don't need to get that if you're 6 years old, 7-year-old, 8-year-old. You wait till they're in puberty. All you get is false positive tests. You had a question? What is it? Oh, it's a test they do to see if you've had any changes in that glomerular basement membrane in your kidney, where protein albumin that's normally in your blood begins to leak through the kidney and be seen in the urine. It's a very early sign of potential diabetic kidney problems. It's very contaminated by false results. Some people, when they're standing, will spill protein. So it's often best to get it first thing in the morning. When you first get a sample, you can, if it's not exactly clean, if that urine has washed over anything, whether it be foreskin or labial folds or things like that, you'll get a little protein in there and you'll get a false positive. And then you got to get another test done. And then you got to get another test done. So the main thing is don't do it until there's really some risk of having actual diabetic kidney disease. And at each visit, you should consider psychosocial issues at the visit. Appropriate referrals should be made. Mental health care professionals should be a part of your team. You guys have seen Jessie, maybe she's part of our team. Adolescents should have individual time with the caregivers away from the parents. And you should screen for eating disorders at 10 to 12 years of age. And there's a standardized survey they do. Type 1 diabetes education at diagnosis, and then again, it's a whole team, and routinely afterwards, individualized medical nutrition therapy. There should be someone giving nutrition and can be there to help you with that, because we still do carb counting. And physical activity is recommended about an hour a day, and education on how to manage glycemic control with different forms of exercise should be provided. The issues with children less than 6. This is I just looked at this recently at the ATTD meeting, so I'm going to give you just a few slides because I think this is the group. If you can handle this group, you can handle almost any group. They have really rapid changes. They have a greater, what we call coefficient of variation. The glucose is going up and down. They often can't recognize hypoglycemia. They can't verbalize it necessarily. If you withdraw insulin from them very rapidly, they can develop ketones. In fact, it's not uncommon to have 0.2, 0.3, 0.4% blood ketone levels in the morning. Kids, just because they fast, they have big brains, which consume a lot of glucose in relation to their body size, and they begin to break down fats to keep the glucose up. It's common physiology in a younger child. But if you withdraw insulin very quickly, their ketones can go up. Appetite, activity levels are unpredictable. They're grazing through the day. they only want bananas one day and hot dogs the next day, you know, who knows? So they're sensitive to very small doses of insulin, and they generally get 6 or 12 viral infections a year. So you're just constantly dealing with some illness. And this is a study we were doing with a closed loop system, and this was in an Airbnb. And I had a research coordinator following the kids around. They had tablets looking at their glucose levels. And I saw this kid sort of about there, sort of walking, and he sort of was walking slower, and then he just fell down to the ground, just collapsed. And so I said, the guy that was there said, "What's his glucose?" And his sensor said 163. And I got to him, did a finger poke, and let me see here. I'm losing there. And by the time I got the finger poke, he said his glucose is 88, and the finger poke was 36. And this rate of change, 15 milligrams per DL per minute, is really fast. And these kids will do that. and I almost didn't believe parents when they tell me it would go this quick, but I certainly do now. And you look at the rate of change of the glucose values, and this is looking at breakfast, lunch, and dinner. And at breakfast, it can go greater than 2 quite frequently, 80% of the time. And it can even go greater than 4 milligrams per DL per minute. So their blood sugars with food also go up really rapidly. And breakfast is the most common place. So there have been closed loop studies with toddlers. This is a tandem study that was done. And I just want to show you at home for 3 days, they had 68% time in range, 1.4% incidence of hypoglycemia. This is an Omnipod study in toddlers. This is 80. It was a nice big study. And there was a time in range that was 68% with 2.5% hypoglycemia. And one of the things I liked about this study, they looked for the Pittsburgh Sleep Quality Index. And if you're less than 5, you're getting a good night's sleep. And they were able to achieve that for these parents. And that's really important, because if you have a young kid and and you don't have automated insulin delivery overnight, you're up once or twice a night. So, and there was another study that was done on the 670G in toddlers. And again, they got this good improvement, and the nights look much, much better. So in general, basal rates vary as children grow. You have the highest basal rates. Often young kids have a evening dawn where they're more resistant between 9 p.m. to midnight. And then somewhere it's sort of that magic witching hour around midnight, 1 o'clock, all of a sudden they become really sensitive to insulin. So if you gave enough insulin to cover what they were doing in the early evening, all of a sudden that tail of insulin is too much and they're dropping. And it's been one of the bigger challenges we've had. Pubertal children, they have their dawn phenomenon when dawn occurs, generally 3 a.m. and it lasts through about 9 a.m. And occasionally they're a little bit higher, 9 p.m. to midnight. So when younger kids are going to sleep, they're releasing growth hormone, cortisol, and all these hormones that create insulin resistance. And that's why they have more. Okay. And I was going to go through diabetes. I think I am over my time. So these were guidelines we talked about, just issues dealing with school. But one of the things is to really make sure that the child can treat himself, that he can get food, that he can go to the bathroom, that you have adult personnel there that can know how to manage and help to give insulin, glucagon, and that the child's privacy is protected if they want it. That again, she can eat when they need to. If they're low, they can eat in class even. So there's a whole set of these, and these have been well published over the years. But they need to have access to water, and they can test in the classroom. Don't have to do many finger sticks if you're on a CGM. So that's really changed that a lot. And I just want to say this was the California Senate bill, and Rayhan sent me this last night. And I think this is probably what I want to leave with. Our California governor, Gavin Newsom, announced yesterday that he'd approved a budget that allocates $100 million for the state to create and deliver its own insulin for its citizens. It's going to cost somewhere around $30, $35 a bottle. And he said nothing epitomizes market failures more than the cost of insulin. Many Americans experience out-of-pocket costs that are $300 to $500 a month for a life-saving drug. California is now taking matters into our own hands. And, you know, this has been due to advocacy. And I think the next advocacy should be make sure that insulin comes straight to them. They can get it by Amazon or something like that from the factory. Then cut out all the middlemen. It isn't so much the cost of a vial of insulin. When the insulin was $350, I could go to Canada and get a vial for $30, $35. And the insulin company is still making money selling it in Canada. It's all the people in between. And we really need to change, and you need to advocate to get rid of this. I mean, the Canadians, Banting and Best, when they had their patent on insulin, they sold it to Lilly for $1 because they felt it was a life-saving drug and it shouldn't be for profit. It should be to help people. That's why they did it. And we got to get things going again. Our healthcare system is for profit. In America, healthcare is a privilege, it's not a right. And we got to change the system. And it's people advocating for their children that can do that. So I'm going to stop. These are my key points. The complications are much less now. The burden of diabetes is decreasing. It's, sleep is much better and safer. We're going to see systems that will eliminate carb counting in the next few years. In 5 to 10 years, we may have islet replacement. Do physical activity. It's good. Enjoy life. And do not let perfection be the enemy of good. Rayhan.
Going to thank Bruce, as always, for a wonderful presentation. He was talking about physicians who put their own well-being second to that of the people they provide care for. Bruce is one of those. I have seen him playing a basketball game with the kids in a study, break his hand and continue going on playing and and carrying out that study, because that's the kind of doctor and person that he is. So I'm going to talk a little bit about the adult perspective. As many of you know, the majority of people with type 1 are not kids, right? We're adults. Here are some of my disclosures. Just want to tell you about my background real quick here. So I've had type 1 for about 30 plus years. Growing up, I never wanted to do anything diabetes related. I was a huge nerd, so I wanted to be an electrical engineer and computer scientist. So I went to UC Berkeley, got a degree in engineering, and I was quite happily working in industry when my 2 younger sisters got type 1 diabetes as well. So when that happened, I decided I had to shift gears, move into medicine so I could help my brothers and sisters out there with diabetes. And I was coming to the end of medical school, and I was like, well, my middle sister was an adult when she was diagnosed. My youngest sister was very much a kid when she was diagnosed. So is there any way that I can take care of people of all ages with diabetes? And as it turns out, there is this thing called MedPeds offered at a couple of places in California. So I did an internal medicine and pediatrics residency at LA County Hospital, which is a very underserved population that we see there. At that hospital, we care for the undocumented. And as many of you know, in this country, we treat the undocumented as if they are criminals. And I would have children coming to me in tears asking why their doctor could have access to an insulin pump and they could not. So disparity is very much alive and well in the US healthcare system. After that, went to Stanford to work with people like Bruce, and really wanted to reconnect the engineering and diabetes together. So I've been working as a physician and clinical researcher at Stanford for the last 7-8 years now. So this is a picture from 2016 at Diabetes Camp. Bruce was, of course, here. I wanted to talk about some of the challenges we face for adults with type 1 diabetes. And actually, one of the big challenges that a lot of people don't talk about is that we lose a huge number of people who had been seeing a pediatric endocrinologist. They actually don't make it to their first 2 adult endo visits. It's actually the majority who don't. And after we just have to get somebody in the door, the next step is how do we get them access to the tools they need, right? With the Affordable Care Act, we can have young people stay on the health plans of their parents, but only up to a certain extent, right? So when you're 27 now, you're getting usually kicked off. And so now it suddenly becomes the responsibility of the person with diabetes to now get access to the same technology, the same insulin, and getting all of that costs money. And we know that inflation is on the rise, salaries are on a downfall relative to that inflation. So it's very hard for young people these days to both afford a roof over their head and the insulin they need and the tools that they need. A big part of managing diabetes is just how is life going? All those psychosocial challenges that we all face on a daily basis have an impact on glycemia. In fact, most of the time, I spend my visit not talking about, hey, how do we change this basal or this carb ratio? It's spent on saying, how's life going? Is everything going okay at work, at home, at school? Because if things are going wrong in life, then likely that will carry over to the diabetes. And if everything's going wonderful in life, likely that will carry over to the diabetes. So glucose control just becomes a surrogate for how is life going and how much access do I have to care, right? So if you have both of those things, then most of the time people do reasonable. If you don't have access to the tools you need, then it's going to be much trickier. If you don't have a job, you don't have the ability to feed your family, you're not going to have the ability to take care of your diabetes. So the goals for me for adult diabetes management, and Bruce presented a lot of these standards of care guidelines, which are, of course, very important. And, we want to do our screenings. We want to keep everyone in the appropriate targets. But really, to me, is get the person in the door and keep them coming to the visits. Because if you don't engage someone and retain contact, it's very easy if you're, 20, 30-year-old individual to say, well, I've been handling this for a decade plus, I really don't need anyone telling me how to do it anymore. And so I'm just going to go about my way and try to do it on my own. And then you miss out on the screenings, you miss out on, hey, what are the latest technological developments? And unfortunately, when that happens, there is oftentimes a backslide in terms of glycemia and attention paid to the diabetes. I make sure to try to address the life and access issues as much as possible. I can't tell you in our healthcare system how much effort is spent on prior authorizations, pharmacy prescriptions. Then the pharmacy says, oh, we don't cover this brand, so you have to switch it to the other brand. It's such a waste of resources. But realistically, if you can't get the individual what they need, then you're not doing them a service. So you really have to get them the access they need as much as possible, spend the extra time. And then, you know, in the pediatric clinic, we often talk about these multidisciplinary teams. In the adult clinic, we have those resources, but they're not sitting there at that visit. So it's also super important that if somebody needs a social worker, a psychologist, a psychiatrist, that you have the ability to get them there in a hurry. So that, to me, is a big part of making sure that we're addressing the life issues as much as possible, connecting people to jobs, connecting people to the tools they need to live successfully. And also housing, because that is a crisis right now in some parts of the country. We want to influence behavioral changes. So how do you, Facebook has gotten this figured out. How do you get people to buy widgets, right? Connectedness. You take a person and you connect them to someone who's similar along 9 out of 10 metrics, except the one thing this guy buys you're not currently buying. And you say, well, look how connected you are to this other person, and use that to drive that behavior. So for better or worse, they use it to sell widgets. I try to use it to get people to modify their behavior for diabetes. So I use my connectedness. Hey, listen, we're both people living with diabetes, to try to drive glucose control and help people avoid complications. And if complications occur in the adult side, we also have to engage in whatever risk reduction strategies we can to help people deal with those things. And I just want to talk about the fact that, you know, 500,000 youths with special healthcare needs turn 18 every year. So that's a lot of people needing transfer from a pediatric clinic to an adult clinic. And though it's not specific to diabetes, we often use that as a model of chronic disease when examining the literature. And there's not a lot of great evidence for anything that we do in terms of moving people from the pediatric to adult world. But we do know that the majority of those with type 1 report a negative transition experience, 21% decrease in clinic attendance, and more than half change adult providers at least once. We know that unstructured transition of adolescents with type 1 diabetes results in significantly higher A1C, less follow-up, and young adults with type 2 diabetes encounter the same worsening of glycemic control. So unstructured transfers do not work. Merely introducing the adult provider at a pediatric visit doesn't work. An 18-year retrospective of people with another endocrine condition, congenital adrenal hyperplasia, over the age of 16 showed that 50% were lost to follow-up after 2 adult visits. And every pediatrician seems to think that they are the sole owner of the responsibility of transfer. It's a very pediatric thing to believe that, you know, if someone doesn't make it to the adult side, it's my fault as a pediatrician. It's all nonsense, right? It takes 2 to tango here. You have to have an adult provider who's willing to meet the person halfway. If this were a game of baseball, it's not just the pitcher's fault when the ball doesn't make it past the plate. You have to have a receiver there on the other end to help with this. Okay, and as Bruce pointed out in the slide, you'll keep seeing every one of these presentations is basically that we aim for these really lofty targets for A1C. And some countries with nationalized healthcare, they do achieve some of these targets. But even in the most economically privileged society in the world, this is how we're doing. And it actually got worse. The 2010 to 2012 data is in red, and the 2016 to 2018 data is in blue. So things actually went up. And this crucial period of transition, which I've highlighted in yellow, is complicated by ketoacidosis, emergency department visits, hospitalizations. And guess what? The T1D exchange data, the curve that you almost always see in these presentations, that's at the expert diabetes centers. That's at the places where we're supposed to be delivering the world's best diabetes care, right? So this is not actually the sample from the real world. There's another database from the Optum Humedica electronic health record database. This is basically just a big data dump from all the medical record systems that we have access to. And you find that if you look at that data, the A1C curve is even higher. And one of the things that I think happens in this transfer, right, is if you have lived with diabetes for a while and have gotten positive feedback about your performance at every interval, then you are very likely to continue to do well and keep coming back to the visits. And the people who are chastised because of low blood sugar, high blood sugar, they just don't show up to clinic anymore because they don't have to, right? And so where do individuals who are underserved with diabetes go? We know that at least several thousand of them in California and Florida actually just end up seeing primary care doctors rather than endocrinologists. And nothing wrong with that inherently, but we then have to make sure our primary care doctors know how to take care of diabetes. So I just wanted to highlight the differences between the pediatric clinic and the adult clinic. In our pediatric clinic, we have a social worker, educator, nutritionist, a diabetes psychologist, and they're all in one house, right? They're there for the visit for every patient. And we even have this sort of big board where we can see who has seen the patient that day. In adult endocrinology, we have those same resources, but you generally have to refer out to get the person to see that provider. So it takes a really dynamic collaboration to help achieve the long-term outcomes. And you'll notice that when someone is in pediatrics, parents will very easily call for issues related to their children, but when their care is in their own hands, they don't reach out anywhere near as commonly. So I did want to just report here, and if people can read about this themselves, but if you ever have a chance, we put out a paper on a method of moving folks from the pediatric world to the adult world called the guided transfer of care. Basically, if you're an adult provider and you can come to the pediatric world, engage the person there, it seems like you can get a better show rate. And indeed, that's exactly what we found. Effectively, if you just refer someone blindly to my clinic, the traditional transfer, there's about a 46% chance that they show up. Whereas if I saw them first in pediatrics, there's a 100% chance they showed my adult clinic. Okay, so as pediatricians, as adult doctors, we must remember that the majority of those with diabetes are adults, and our success as a pediatric care provider is only as good as the long-term outcomes of those under our care, right? So great, you've maintained someone's A1C till they're 18, but they still got 20s, 30s, 40s, 50s, 60s, 70s, 80s. And yes, the stuff we do in the beginning is very important, but we need to keep them going for that whole lifespan. So a big important message to parents and physicians out there is that our goal with everyone is we want to raise well-adjusted functional adults. So you should keep doing what you were doing with your kid before the diabetes diagnosis, which is raising a well-adjusted adult, right? It's more important than acting as a surrogate artificial pancreas for your kiddo. So the priority should always be try to raise them to take care of themselves eventually, because otherwise, it's a lot of what they associate with the diabetes is associated with you. So if they're having problems with the diabetes, they're going to be having problems with you. And then it makes it very hard for them to approach it if those two things are inextricably linked. And we want to make sure that young people are able to make their own health conscious decisions. So we want to make sure that young adults become independent, engage adult providers, make sure that transfer is considered a shared challenge between pediatrics and the adult doctors, not just the pediatrician. And anchoring a young adult to an adult provider through the guided transfer is a potential way we can do it. And we're currently investigating this with some of our adult endocrinologists coming into our pediatric endocrine clinic. Okay, and I just want to say thank you to both the peds and adult endocrine teams at Stanford. You can guess which one is which by what they're wearing in these pictures. And my mentor, Dr. Bruce Buckingham, who gave the first half of this talk. And thank you to the NIH for paying my salary. Okay, guys. So I'm going to invite Bruce back up to the stage here, and we will have a few minutes for questions here.
I'm not wearing a face mask. I'll stand 6 feet away from you. I know there are a lot of you that are back there. You have a mic, which is really helpful. Thank you.
When we hear the metrics about how people are doing, retinopathy is the thing I think I always hear. Is that the leading complication that we see, or the first one that we see? If there are them?
It's a great question. As Bruce was alluding to, these collagen deposits occur everywhere, right? It's actually very seldom that you see retinal disease without any kidney disease. And it's very rare that these things occur entirely independent of one another. Now, our ability to detect them, those occur at different thresholds. So if you ever see on a report, sometimes they'll say non-proliferative retinopathy on a report. That can sort of wax and wane with respect to glycemic control. It's really the proliferative retinopathy where it starts to get vision threatening. So this is one of those situations where you do see some ability to detect those very early, and microalbumin screens can detect kidney disease very early. So those things oftentimes go hand in hand. But one of the things to remember is if you have, reasonably controlled glucoses, this is a decades-long process. This is not a few weeks of hyperglycemia and you have retinopathy. No, not a few months, not even a few years, but really a long-standing issue before you run into these complications.
I was just wondering, is there enough endocrinologist doctors?
No.
Because my daughter went from pediatric to adult endo, and they gave us a list of doctors at her last appointment with the pediatric. And then we had to go through each one, and it was very frustrating to find out, we can't get you in for 3 months. And then the good doctor is longer. So my question, like you said, you already answered, there's not enough.
There isn't. That is one of the biggest health challenges in endocrinology is there are 1,500 pediatric endocrinologists in the country, and there are about 6,500 adult endocrinologists in the country. Now, 10% of the US population has type 2 diabetes. Can you, with a few thousand providers, can you deal with 10% of the US population? No, it's impossible. And a lot of people talk about telehealth as if that's the savior in all this, but it's not, right? You only have so many people with so many slots. And once those are all full, be it in person or telehealth, you're kind of at an impasse. So one of the projects that we work at on Stanford is trying to disseminate our knowledge to those primary care providers through a model called ECHO, so that we have some expert diabetes primary care doctors who can help with this. And that's the only way. You have to democratize the knowledge so that more people can take care of individuals living with diabetes.
Yeah, I wonder if you could talk a little more about the, Bruce, you had a slide about the LDL screening for pre-puberty, 9, 10, 11-year-olds. What kind of values to look out for? Our endocrinologist suggested that while it's good to screen, this isn't something to be super worried about, that after puberty, if you have somewhat elevated cholesterol levels after puberty, they're going to come down. So we wonder what is the appropriate level of concern.
Yeah, so the level is set at 100 is sort of the threshold for the LDL cholesterol. And the question is, what do you do about it? And so you can always, the simplest thing is always maybe a little diet, maybe avoid some of the foods that might do it. But the reason you screen at diagnosis or shortly afterwards and then right before puberty is because the LDL cholesterol is also inherited. And you can get a heterozygote that will elevate it. And then it's a hereditary condition and not related, say, to the diabetes. And the diabetes, if you're in poor control, can also affect that cholesterol. And it used to be, particularly triglycerides, LDL cholesterol, used to be a measure of someone in poor control. And so one of it would, but if you're in reason, there's, the question is when you're going to begin a statin, when you're going to begin a pharmacologic therapy. And if you have one, will you begin it prior to puberty? Will you begin it after puberty? And what is the right age to do that? And it's partly based on just how high it is and what you do the typical things like with some diet modification. If someone has a significant one, it is an additional risk factor for cardiovascular disease. And we talked about eye and kidney, but on a long-term basis, cardiovascular is a big issue now with diabetes. So you want to modify that risk factor and not have them live, does someone have a heart attack when they're 16 years old or 18-year-old? No, but you have a cumulative effect on those vessels. So at some point in time, you want to get that LDL down. And it's always a matter of side effects and risk. Statins are pretty well tolerated. So, do you want to add any more?
I totally agree with everything Bruce has just said. I think the reality is the number one killer of people with diabetes right now is cardiovascular disease eventually. And the reality is every time the adult cholesterol guidelines change, it takes about another 5-6 years before the pediatric guidelines change. So I don't know if any of you guys get your cholesterol checked, but the way we're supposed to do it now is you plug data into a 10-year risk of heart attack or stroke calculator, and you see what that value is. And if your 10-year risk is above a certain critical threshold, then you'll say we'll start moderate dose statins or high dose statins as a means of reducing that risk. And we do not necessarily have longitudinal data in pediatrics to create such a risk calculator, because following kids for a couple decades is hard. But eventually, hopefully, we incorporate those sorts of tools into practice.
Unless you live in a more developed country.
In which case we track people.
Okay. Yeah. Okay. Yes.
You had a slide up there showing that you would diagnose that you have them range, not that you, but they were range 85% of the time. My question is that if they had a tandem system or what factors led to them being that range?
Well, this is a study, and I don't have the results of it yet to tell you, but when they're in a honeymoon, when they're making their own insulin, very easy to keep them at 85% time in range, because their own islet cells are regulating the glucose levels.
But yes, with closed loop. I don't
No,
want
no,
anyone
no,
to feel.
with or without closed loop.
I don't want anyone to feel bad if they're not making it to 85% time in the first year.
Okay, and it's not in the whole first year, but when you're generally, you know, the honeymoon is definitely there at 3 months or something like that, and it depends partly on age group. But if you're making a lot of your own insulin, it's pretty easy to do. And actually, one thing that comes up sometimes is about 2% on CGM of people that are normal have glucose values between 65 and 70. And overnight, for people who don't have diabetes, they can be running in 65 to 70 range. And so where do you set that threshold at night? So often when someone's in a honeymoon, they're not going to get low because they aren't taking much insulin. So we actually set the alarm at night at 65 instead of 70, so people could get sleep. And but we were doing we did a study, it's through JDRF, and 50% were put on automated insulin delivery, and 50% were given a medication, verapamil, to see if it would prolong and improve the honeymoon. And in that study, a lot of the kids we were following were getting this 85% time in range. And there were 4 arms. So one got placebo, one got placebo plus closed loop, one got verapamil, and one got verapamil plus closed loop. So there are 4 groups, and we're blinded. So I don't know who got what. I know who got closed loop, but I don't know who got the verapamil. But there were a lot that were coming out meeting that target at the end of the year. And so we will find out in a few months, and maybe in 4 or 5 months, it'll be published. We're expecting something was doing something, because we don't normally see that. And I don't think you should expect to necessarily see that unless someone's in their own honeymoon. Or anyway, it was a study to do everything we could to see if we could prolong the honeymoon and maybe change the standards of therapy for when someone is first diagnosed. The verapamil stops or decreases the risk of islet cells dying. It prevents islet cell apoptosis, which is islet cell death. That's the theory behind it.
Thank you to everyone. Really appreciate everyone attending.